Welcome to The Explainer. Today we're unpacking the clinical guidelines for Wilms tumor and really transforming what is undeniably a terrifying childhood disease into a clear, understandable map of medical triumph. If you've ever wondered exactly how modern medicine tackles one of the most formidable pediatric cancers out there, well, you're absolutely in the right place. We're going to walk through the complete patient journey today, and we'll be relying strictly on the clinical data to illuminate everything from the initial microscopic spark of the disease all the way to the incredible survival rates we're seeing right now. All right, let's jump right in. Just how dominant is this disease? Well, Wilms tumor isn't just a type of childhood kidney cancer, it practically is the childhood kidney cancer. It accounts for a massive 90 to 95% of all kidney cancers in kids. So when a medical team is faced with a pediatric renal mass, this is the primary adversary they're gearing up to face.
To ground us here, the medical definition calls it nephroblastoma. Wilms tumor is a childhood cancer characterized by the abnormal proliferation of immature kidney tissue. The key words you really want to focus on here are embryonal and primitive. We aren't talking about normal adult cells going rogue. We're dealing with a disruption in the very early foundational building blocks of the kidney itself.
We'll be navigating this patient journey in 5 distinct steps: understanding Wilms tumor, spotting the warning signs, diagnosing and staging, the medical counterattack, and finally, the road to recovery. Starting off with Section 1, Understanding Wilms tumor, the fetal blueprint error.
So, during normal fetal development, immature kidney cells are supposed to mature into normal filtering units, or nephrons. But in Wilms tumor, some of these embryonic cells just persist after birth. Then, boom, a genetic mutation hits, often in the WT1 or WT2 tumor suppressor genes. This mutation is the spark. It causes those persistent, primitive cells to multiply completely out of control. They form a solid, malignant tumor that eventually compresses the normal kidney tissue, which leads to a loss of renal function.
Now, who does this actually affect? The clinical data shows it primarily strikes toddlers, peaking right around 3 years old. It's slightly more common in girls, and we see a higher incidence in children of African ancestry. And while most cases are entirely sporadic, it is powerfully linked to some very rare congenital anomalies. Syndromes like Wager, Beckwith-Wiedemann, and Denny's-Drash carry a much higher risk because of those shared genetic defects we just talked about. Also, about 1 to 2% of cases are familial.
Moving right along to Section 2, Spotting the Warning Signs, the Discovery.
The absolute most critical sign, and honestly often the very first thing a caregiver notices during a bath or while changing the child, is a firm, smooth, painless mass on one side of the abdomen. But, as the tumor grows and starts compressing surrounding tissues, this fascinating and terrifying cascade of symptoms can trigger. The tumor's compression on the renal blood vessels can trigger excess renin secretion, and that causes severe high blood pressure. If it invades the renal collecting system, you might see blood in the urine. The child might also have an unexplained low-grade fever, anemia, fatigue, or just a sudden loss of appetite.
This brings us to a massive, absolute warning for any parent, caregiver, or nurse assessing a child with a suspected abdominal mass. You will see this plastered across medical guidelines everywhere. Do not forcefully palpate or press on the abdomen.
Why? Because the tumor is encapsulated, and physical pressure, even just rough handling, can literally burst that capsule. If it ruptures, it spills malignant cancer cells all throughout the previously uncontaminated abdominal cavity. It causes internal bleeding, puts the child into shock, and immediately, drastically worsens their clinical stage and long-term prognosis. It is an entirely preventable disaster.
Which leads us straight into Section 3, Diagnosing and Staging, the assessment.
Once the team knows what they might be dealing with, they bring out a very specific arsenal of imaging. They always start with an abdominal ultrasound. It's fast, it's not invasive, and crucially, no radiation for the child. From there, they escalate to CT scans or MRIs to check if the tumor has invaded local blood vessels. They also urgently check the chest with an X-ray or CT because the lungs are the most common site for this cancer to spread. Notably, they specifically avoid sticking a needle in for a biopsy before surgery. Again, they want to completely prevent that immense risk of tumor spillage. All that assessment helps build our staging map based on the National Wilms Tumor Study Group system. Stage 1 is your best-case scenario. It's totally confined to the kidney and fully removed. Stage 2 means it grew just outside the kidney, but again was completely removed. By Stage 3, some residual tumor was left behind in the abdomen, or maybe it spilled during surgery. Stage 4 is distant metastasis, meaning the cancer reached the lungs, liver, bone, or brain. And Stage V is a unique category. It means the tumor has struck both kidneys at the same time, which requires some incredibly careful surgical planning to save enough kidney tissue to keep that child off dialysis. Now for Section 4, the medical counterattack, treatment and care.
Our counterattack here relies on two massive complementary pillars. On one side, we have medical management, leaning heavily on chemotherapy. Drugs like vincristine and doxorubicin are used either before surgery to shrink a massive tumor down to a workable size or after surgery to mop up any microscopic rogue cells. Contrasted directly with this is the surgical management. The main move is a radical nephrectomy, completely taking out the affected kidney, the tumor, and the surrounding tissues. If the child has stage 5 bilateral tumors, they'll attempt a partial nephrectomy, carefully carving out the tumor while desperately trying to preserve any healthy, functioning kidney tissue.
But listen, surgery and drugs, they aren't the whole story. The clinical guidelines deeply emphasize the day-to-day heroism of nursing management. The medical team has to constantly monitor abdominal girth and blood pressure to dodge hypertensive crises. They're perfectly balancing fluids, meticulously managing severe pain, and maintaining strict asepsis to protect an immunocompromised child from lethal infections. And beyond the physical toll, they're tasked with providing deep psychological support to terrified parents and a young child enduring a really traumatic process.
Throughout all of this, the medical team is constantly watching out for severe complications. These can come straight from the tumor itself, like a spontaneous rupture causing internal bleeding and shock, or renal failure. But ironically, complications also arise as toxic side effects from the heavy-hitting treatments designed to save the child's life. Chemo can suppress the bone marrow and damage the remaining kidney. Radiotherapy, if they have to use it, can cause late-stage effects down the line, like growth retardation. It really is a razor-thin tightrope of risk versus reward.
Finally, Section 5, the road to recovery, the triumph.
Prognosis isn't just one static number. It heavily depends on a few distinct variables. The stage at diagnosis is vital, obviously, as is the child's age. But what the source material stresses the absolute most is the histology. When pathologists look at the tumor under a microscope, they want to see favorable histology, which basically means the cells are structurally responsive to modern chemotherapy. If they see anaplasia, or unfavorable histology, the tumor is much more aggressive and a lot harder to treat.
But here is the absolutely incredible payoff for all that science and all that care. Thanks to advances in combined surgical techniques and modern chemo protocols, the overall survival rate for early-stage, favorable histology Wilms tumor is now greater than 90%. More than 90%. A diagnosis that was near certain tragedy just a few decades ago is now quite literally one of the greatest success stories in all of pediatric oncology.
That remarkable statistic leaves us with a real thought to chew on as we wrap up this explainer. If early detection, finding that painless mass before it spreads or ruptures, is the absolute key to locking in that 90+% survival rate, how can we ensure every single parent, caregiver, and frontline health worker knows exactly what to look for? Because awareness really is the first step in the cure. Thank you for joining me to unpack the science and the patient journey behind Wilms tumor. Keep learning, keep asking questions, and I'll see you in the next explainer.